Hey everyone, and welcome to this rapid-fire explainer. If you've ever felt completely overwhelmed by the sheer complexity of thrombotic microangiopathies, well, you are in exactly the right place. Today, we're going to build the definitive, absolute clinical cheat sheet for hemolytic uremic syndrome. We're stripping away all the fluff to give you just the direct essential facts. We're going to lock down exactly what you need to know about HUS, in order from the microscopic root causes all the way to bedside management.
Okay, let's jump right in and define exactly what we're looking at. At its core, hemolytic uremic syndrome is essentially this catastrophic combination of two things: red blood cell destruction, which we officially call microangiopathic hemolytic anemia, or MAHA, and acute kidney failure. This whole destructive process is driven by severe injury to the endothelial cells that line our blood vessels. That injury is what leads to these tiny, microscopic clots forming right in the terminal vessels.
So, here's our game plan for today's explainer. We're going to hit the causes of HUS, dive into the pathophysiology, break down the clinical signs and symptoms, and then wrap up with investigation and management protocols.
All right, kicking things off with Section 1, the root causes of HUS, specifically looking at typical versus atypical.
Clinically speaking, HUS splits into two totally distinct camps. Think of it like this. We have typical HUS, which is usually triggered by an outside invader, like a bacterial infection. Then we have atypical HUS, which is more of an inside job driven by an internal regulatory failure. You might have actually heard typical HUS called diarrhea-associated HUS in the past, while atypical HUS is basically a complement-mediated disease. Let's look a little closer at what actually triggers these two.
For typical US, the usual suspect is Shiga toxin-producing E. coli, specifically that infamous O157H7 strain, or sometimes Shigella. But it can also be caused by Streptococcus pneumoniae. That bug produces a neuraminidase enzyme that actually exposes hidden cryptic antigens on platelets. Now, atypical US, on the other hand, is usually a genetic or autoimmune failure. It very frequently involves a factor H mutation that just leaves the alternative complement pathway completely unchecked. There's even an autoimmune variant called DAP-US, where autoantibodies literally block factor H from doing its job.
Moving right along to Section 2, the pathophysiology, or what I like to call the cellular battlefield.
With typical HUS, it's a very specific chain reaction. First, that Shiga toxin gets into the bloodstream, and it specifically hunts down and binds to GB3 glycolipid receptors on the endothelial cells. Once it binds and forces its way inside the cells, it sets off an alarm, inducing a massive release of inflammatory cytokines like IL-8 and MCP1. This localized explosion of inflammation rapidly triggers platelets to clump together, creating those microscopic clots that define the microangiopathy.
Now, contrast that with atypical HUS. Remember how I said it's an inside job? Well, because of missing or broken regulatory proteins, most commonly our friend factor H, the alternative complement pathway is never actually told to turn off. It just stays on, continuously activating, which leads to this rampant, uninhibited attack on the body's own endothelium. And that sparks the exact same deadly clotting cascade.
Let's pivot to Section 3, what this actually looks like when the patient is right in front of you, the clinical signs and symptoms. What's honestly fascinating here is that every single symptom connects directly back to a mechanical cause. It's like a puzzle fitting together. In typical HUS, you're going to see a prodrome of bloody diarrhea and vomiting that precedes the anemia by about a week. The MAH itself? That happens because red blood cells are literally being sheared apart as they force their way through these microscopic webs of fibrin and platelets. You see thrombocytopenia because the body is entirely consuming its platelet supply just to make those microthrombi. You'll see acute kidney injury and oliguria because those clots are choking the kidneys. And you can even see severe neurologic deficits like dysphagia or seizures, especially in adults, when those clots hit the central nervous system.
Now you might be wondering, why the kidneys? Why do they take the absolute hardest hit during typical HUS? Well, it's definitely not a coincidence. It's simply because the microvasculature in the kidneys is absolutely covered with those specific GB3 receptors. It makes the kidneys a massively target-rich environment for the Shiga toxin, basically turning them into ground zero for the damage.
Okay, time for Section 4, the investigation protocols. How do we actually step-by-step diagnose this in the lab? First things first, our first line of defense is confirming MHI. We do this by getting a peripheral blood smear and actively hunting for schistocytes. Those are the sheared, fragmented red blood cells we talked about. We'll also immediately check LDH and haptoglobin. We're expecting an elevated LDH and a low haptoglobin from all that hemolysis.
But crucially, we absolutely have to check ADMTS13 activity. We're looking for activity greater than 5 to 10%, because if it drops lower than that, we're likely dealing with a similar but entirely distinct disease called TTP, not HUS.
But what if we suspect atypical HUS instead? Well, our focus instantly shifts over to the complement pathway. We are specifically looking for a low C3 level, but paired with a normal C4 level. That very specific combination points the finger directly at alternative pathway dysregulation. From there, we'd move right to genetic screening for factor H or CD46 mutations, and we test for those deep HUS autoantibodies to nail down a definitive diagnosis.
Finally, let's get into Section 5, Management Protocols, because to put out this fire, you have to know exactly what kind of fire you're fighting.
Okay, before we even touch therapeutics, there is a massive and frankly counterintuitive rule you absolutely must remember. Do not give antibiotics or antimotility agents to kids with typical STEC HUS. It can actually fan the flames and make the disease so much worse. Studies show it actively increases the incidence of the syndrome, likely because as the bacteria die off from the antibiotics, they release a massive, accelerated wave of Shiga toxin. Just don't do it.
So here is your ultimate definitive management cheat sheet. For typical STC-US, it requires careful, strict supportive care. Research tells us that plasma exchange is generally totally ineffective here. However, atypical HUS demands aggressive intervention. We use plasma exchange or infusion to replace those missing complement regulatory proteins. And more importantly, we rely heavily on targeted anti-C5 monoclonal antibodies like eculizumab or ravulizumab to physically block that complement cascade from tearing the body apart.
As we wrap up this explainer, I want to leave you with a really fascinating question to think about regarding the future of medicine. We've just seen how these incredibly advanced monoclonal antibodies have completely revolutionized the survival rates for atypical HUS, but it really makes you wonder, how close are we to finally unlocking a targeted therapy to actually disarm the Shiga toxin in typical HUS so we can move beyond just supportive care? It's an absolutely incredible frontier in both nephrology and hematology. Thanks so much for learning with me today, and I really hope this cheat sheet helps you completely master hemolytic uremic syndrome. Catch you next time.